session of the day. And we have a presentation by Sarah Snyder, a professor of history at American University. And she specializes in the history of the Cold War, human rights activism, and US human rights policy. And her most recent book is From Selma to Moscow, How Human Rights Activists Transformed US Foreign Policy, Columbia University Press 2018. And her paper today is entitled Brothers Brother Foundation in Costa Rica, a case study in public-private partnerships and global health in the American century. And it gives me great pleasure to welcome our commentator, Professor Inderjeet Parmar, Professor of International Politics at City University London, and the author of Foundations of the American Century, the Ford, Carnegie, and Rockefeller Foundations in the Rise of American Power. Sarah, the floor is yours for 10 minutes. Thank you.
Great. Thank you so much for having me. As the description that Giles just gave suggests, I'm a bit of an interloper here in this conference on public health, and I'm just so delighted that you invited me to participate because I have learned so much thus far in the conference. So the US government historically has supported humanitarian organizations in many ways, and it offered key logistical support to the immunization campaigns that Robert Hinkson and the NGO that he founded, the Brothers Brother Foundation, the campaigns that they undertook in the 1960s. In an article in the historical journal, Guns of Peace, an early campaign against smallpox, I've written about Hinkson and Brothers Brother Foundation's smallpox vaccination campaign in Liberia in 1962, and the ways in which the US government offered critical support, including transportation. What I want to talk about today is Brothers Brother Foundation and the US government's cooperation in Costa Rica. So at the end of August 1967, the Costa Rican Minister of Health, Alvaro Aguilar, wrote to the US President, Lyndon B. Johnson, thanking the Department of Defense for loaning 16 jet injectors, which he termed Pistolas de la Paz, for a vaccination campaign against smallpox, measles, and polio. Now, Johnson was intrigued by the minister's language, which transformed vaccine delivery vehicles into transmitters of peace. A note that he wrote in September of 1967 said, "Find out what this is and have Covey Oliver develop a program. Pistols for Peace. That sounds pretty good." Now, this immunization campaign in Costa Rica involved collaboration among the United States, the Costa Rican government, and Brothers Brother Foundation. The foundation provided US medical professionals and utilized resources such as the Pentagon's loan of jet injectors. Brothers Brother Foundation had reached out to Latin American governments in 1967, offering medical missions to immunize against polio, tuberculosis, leprosy, smallpox, and measles. And Aguilar, the Costa Rican health minister, responded in early June asking for help combating a measles epidemic in the country. In response, Hinkson and his foundation organized a complex operation that vaccinated 846,000 Costa Ricans against smallpox and immunized them against measles and polio. Now, US government officials in San Jose and reporters in the United States tracked the effort. The New York Times covered the 84 volunteers, including members of the Hinkson family, who were set to travel to Costa Rica for a month and participate in the campaign. Initially, Brothers Brother Foundation faced challenges in securing sufficient doses of the measles vaccine, and so they turned to, among other people, the US ambassador to Costa Rica, Clarence Boonstra. Also, the Pan American Health Organization, the regional office of the WHO, provided some doses of the vaccine, and the health department in New York City also contributed from its stockpile. And I was thinking, looking at the photographs during the keynote address yesterday, that perhaps these doses were left over from the efforts to combat the outbreak of smallpox in 1947. I'm not sure about that, but I was sort of intrigued by the photos and wondering about the New York City stockpile. Now, given the urgency and the scope of the epidemic, Brothers Brother Foundation ultimately ended up buying vaccine doses beyond its available funds, and this led to ongoing financial problems for the organization. Now, beyond vaccines, Brother Foundation also needed jet injectors to deliver these doses, and significantly, the Pentagon lent them 16 jet injectors. And a sign of the significance with which the Costa Rican government treated the mission, Hinkson and Brother Foundation team members met with the Costa Rican president, Jose Joaquin Trejos, to discuss their campaign. Reporting on the endeavor back to Washington, the U.S. Embassy characterized their efforts as a success and pointed specifically to the benefits of the jet injector as a method of easing the process. Boonstra, the U.S. ambassador, wrote later to Hinkson, "There's no question but that your program was indeed successful." He wrote, "The campaign has immeasurably strengthened the bonds of friendship and goodwill between Costa Rica and our country." Now, the measles immunizations had dramatic effects, with total cases and measles deaths dropping significantly. Just to give you an example, in 1967, there had been 3,800 Costa Ricans who were hospitalized with measles, whereas the number dropped to 97 in 1968. Now, the Johnson administration's support for the Costa Rican campaign complemented the president's rhetoric about the interconnections between national and international in terms of health and its international health program, which the Johnson administration announced in February of 1966, saying that the United States should participate in an international health effort to, quote, rid mankind of the slavery of ignorance and the scourge of disease. So to conclude, through supporting Brother Foundation and Robert Hinkson's efforts, the United States also benefited from the goodwill and the spirit of cooperation that such humanitarian missions engendered. Writing to Johnson, the Costa Rican health minister said, quote, "We believe our governments should unite in the use of pistolas of peace in preference, wherever possible, to the use of the guns of war." Now, Johnson responded to the Minister of Health's telegram, and he congratulated him on the vaccination campaign. And I think that the potential soft power that these humanitarian efforts engendered, we can see enhance the place of the United States in the world in the American century. Thank you very much.
Thank you very much, Sarah. Inderjeet, the floor is yours.
Great. Thank you so much, Sarah, for your paper and your presentation. Wonderfully brief, and I have a horrible feeling that I might speak longer than you might have. But I'll keep it as brief as possible. But anyway,
well,
Giles.
I'll just interject and say everyone had the opportunity to read my paper in advance, whereas your comments will be new to me and everyone else. So
okay. Well, thank you for that. Thanks, Giles, also for this opportunity as well. And it's been really interesting to kind of think about some of these kinds of issues. And as Sarah said, I am also an interloper in the area of global health. I know very little other than having read E. Richard Brown's Rockefeller Medicine Men about 100 years ago or something like that. But anyhow, I found the paper really very interesting. And I just have some comments and questions about the issue as a whole. As I say, I'm not really familiar with the area of global health, nor am I familiar with Brother Foundation, nor its founder, the very interesting Dr. Robert Hinkson. So I've got 4 areas of comments and questions, 4 broad areas. I start with Hinkson himself. Second, it goes on to the Brother Foundation. Third, I wondered if you might want to comment on this concept of a medical industrial complex which may operate at a global level, as the Ehrenreichs noted way back in the 60s or 70s. And the fourth one is even broader, which is really about the American state and hegemony and the character of American hegemony in philanthropy. So in regard to Hinkson, I mean, from the little bit I read in your paper, and also then I was inspired by your paper to kind of look up Hinkson a little bit more, he seemed like an exceptional human being, a very kind, caring, charitable, innovative, inventive internationalist. And his inoculation gun enabled hundreds of inoculations per hour. And I noted that he even invented the epidural process for women in childbirth to ease that particular kind of discomfort and pain. So I just wondered that if you were to develop the paper further, if you had that plan, that you might want to address Hinkson the man, the person, his ideas, motives, his religion, his politics? Since he operated during the Cold War, what were his views of the Cold War itself as an environment within which he was trying to do a global health, in effect, in his own way? And in regard to the Vietnam War, which was raging at that time too, which he noted in something that you said in your paper, and I think I may have read somewhere else, he noted that the cost of the Vietnam War was so gargantuan, while the cost of inoculating and vaccinating people and protecting them was so little, that there was a kind of mismatch of, if you like, I suppose, mismatch of power. You got this massive spend on coercion, and you got this tiny budget for health, and he obviously wanted to spend a lot more on that kind of area. So I just wondered if you had plans anyway, or if you want to expand a little bit on Hinkson and the kind of individual he was and what made him do what he did, which was clearly exceptional work in the world with great benefits for lots of people. And as you say, particularly in Costa Rica, but also elsewhere as well. And of course, then his second area is his foundation. And I noted that originally the group or the foundation was called Brothers Keeper. But as a result of a Nigerian medical student commenting, he changed the name to Brothers Brother. That is what it should be, not the Brothers Keeper. And so he was clearly kind of responsive to local people, local conditions in some ways. And I wonder to what extent how far that went. And I just wondered also, was his Christian religion the kind of driving force of his motivation? And how bottom up or top down was the Brother Foundation? A lot of foundations, obviously big corporate philanthropies, operate in very technocratic, top down kinds of ways. And I just wondered whether the Brother Foundation, where it sat on that kind of a spectrum, if you like. And I also wondered how idiosyncratic was the Brother Foundation? Was it like an extension of Hinkson's own personality, or did it change once he passed, and did it become something more? The founder often is the inspiration, is the kind of truth and honesty behind the organization. But when it passes on to the next generation of the family or to trustees who are independent, organizations perhaps change in the way in which the ethos with which they operate. And I just wondered if you might say something about that. And also, given COVID-19, Ebola, SARS, HIV, I wondered what the BBF might have done or is doing today in regard to those. And finally, in regard to the foundation, as an Ohio-based organization, how well networked is it with other larger philanthropies? Does it collaborate with them? Is it part of their networks? Does it rely on them? Does it piggyback on them? Does it continue to have close relations with agencies of the American state itself? And where does it raise its funds? Or is it still family money from some level of fundraising? Or where does it find its donors and who are they? The third area would be to do with this medical industrial complex, which, as I noted and discovered only after reading your paper, was a term coined by the Ehrenreichs in the late 1960s, which mimics and invokes the concept of the military industrial complex. And I wondered that although the military industrial complex, if you like, is a construct and many of its elements are gigantic firms on a global scale, but there are also smaller players in its that form part of its hinterland. And I wondered in that regard, is the medical industrial complex useful in analyzing, say, the Gates Foundation and prior Rockefeller health programs, as well as American government initiatives and roles, and the big pharmaceutical companies, and the Brother Foundation? Where did it sit in relation to these other much larger philanthropies, as well as the American state-owned programs? And I think, did it form part of that? As is to say, was it part of a mission which might have been an unwitting sort of manipulation by the American state and other larger forces in whose wake or trail or in their environments that this particular smaller philanthropy operated. I guess I'm asking, how independent was it of these much larger forces, which have very different missions, if you like, than perhaps it itself? And the final is the area of the US state and hegemony, and particularly the character of American hegemony, and in particular, the role of violence and persuasion, and the uses of soft power and hard power. Very often in our discussions about philanthropy and so on, we tend to sort of see them as sort of self-contained expressions of soft power. But actually American hegemony, and hegemony is often understood, particularly by my favorite, Antonio Gramsci, is that hegemony is a combination of force and consent, that the two are not divorced from each other and dichotomous, but actually symbiotic, so that soft power and hard power are deeply closely related. And obviously, even somebody like Joseph Nye, recognizing that soft power institutions have hard power coercive elements, and hard power institutions like the Pentagon also have soft power kinds of operations. And that very neatly sums up the kind of point I'm trying to make here. That is that the American state is much more than just a kind of soft or hard power. It's a combination of the two, due to its own kind of historical peculiarities, and especially because the American state itself has this myth of weak and limited government and so on, and that it historically also formed state-private networks with which Giles and many others are well familiar, and that whole kind of system of parastate institutions like recognized by Eldon Eisenhower from the progressive era onwards, that the state in the US was always relatively limited, but it also formed these alliances and bonds with private institutions which claimed to operate for the public good. And as I said in Gramsci's idea, that political society of force was often combined with civil society of consensus. And I guess all of that challenges the conventional idea of America, that America is not an empire, but actually it is globally networked, present, active, and interventionist, that it isn't really a weak state at all, that it's a very powerful state that can intervene almost anywhere at any time. And it also challenges this idea that actually the United States, especially in its violent forms, is not exceptional, as is often claimed. Very recently, Sarah, I was reading John Dower's book from 2017, The Violent American Century. Very short, but incredibly packs a powerful punch. And I loved this quotation from page 125 of his book, where he sums up the kind of violent character of the American century. He says, quote, "The mystique of exceptional virtue does not accommodate serious consideration of irresponsibility, provocation, intoxication with brute force, paranoia, hubris, reckless and criminal actions, or even criminal negligence," unquote. That suggests that taking violent American empire seriously, but to contextualize philanthropy in specific historical and institutional conjunctures and complexes, but also explore the co-constitution of hegemony through violence and persuasion, soft and hard power, not dichotomous, but symbiotic in that respect. So they're the points which I could think of in regard to asking you about and commenting, which arose from your paper. And I fully recognize that you have your own plans for what you want or not want to do, but these are the thoughts that occurred to me as a result of reading your very interesting and clearly thought-provoking paper. Thank you.
Thanks, Inderjeet, and bang on time. So Sarah, please, floor is yours if you would like to respond.
Yes, I'd love to, in part because this will enable me to talk about some aspects of the project that were not in my presentation or even in the paper necessarily. So I think I'll just go through the issues you raised in the order that you did and begin with talking about Hinkson, who I agree is a fascinating character. Just, I think, for his sort of contributions to medical devices and medical knowledge should have greater recognition, but also for this humanitarian work. And so I really enjoyed learning more about him. I would say that he was responsive to local conditions. And he seemed to me to be potentially uncharacteristically for his time sensitive to the composition of the groups that undertook these missions. In his records, it's very clear that he's focused on ensuring that there's racial diversity among these missions, that there's religious diversity among these doctors and other medical professionals who travel around the world. And I would say, you know, the way in which he identifies people by their denomination in his records, you know, I think it's clear how much his faith motivated these actions. He was very active in the Baptist Church, in organizations like the Baptist World Alliance. Often he would connect with Baptist missionaries when he was traveling. And so and he's spoken in different sort of stages of his life about the ways in which his faith motivated his own work and his desire to sort of improve the health and lives of others, and really kind of making many of his comments around the idea, not just of sort of who was a brother, but who was a neighbor. And I would say implicitly in some of these missions, there is a religious component. There's some distribution of sort of religious texts, some sort of sharing of faith. And so I think that was also in the way of other past medical missionaries, a kind of underlying motivation for some of this work. You asked about how bottom up the foundation was and sort of how idiosyncratic it was. The foundation is run today by a son of Hingson's, so it has stayed within the family. It was definitely very well connected to other Baptist organizations in terms of the funding, either prominent individual Baptists or the Baptist World Alliance in the funding for some of these trips. The other organization that I didn't know as much about the ties to until I published something about the mission in Liberia, and then I heard from Hinkson's son, who said, you know, he had this thing he really wanted to talk to me about. And one of the things that he mentioned was that his father and many of the people who undertook these trips were Rotarians, and that after smallpox was eradicated, Brothers Brother Foundation turned much more to working on polio. And Hinkson, the son, argues that Brothers Brother Foundation sort of laid a foundation for Rotary International's taking up of polio eradication as a significant philanthropic effort. And so I would say that seems to be the strongest connection, as well as some other local Ohio foundations, but I didn't see as much connection to foundations, say like the Rockefeller Foundation or Ford Foundation. The way that they raised funds was through the donation of medical supplies, through people either in advance of their missions or after their missions, giving, in the amount of work involved in this, but very small scale talks to individual churches to raise money for these, relying upon Baptist networks, occasionally also speaking to different groups of Rotarians, but this was small scale, you know, shoe leather fundraising. I didn't see evidence that they got large grants from foundations. I saw the loaning of, say, military equipment or the provision by the U.S. government of, say, transportation. But this often struck me as a very shoestring operation. When they decided to buy more doses for Costa Rica than they had, they spent years retiring that debt. And so, you know, to me, the idea that they're part of a medical industrial complex, if they are, they're a very, very small cog in that complex. I don't think that they don't seem to be benefiting in a material way from this work. In fact, it seems to put a decent amount of strain on the foundation. I was interested that you that you brought up the Gates Foundation, because again, in this conversation that I had with Hingson's son, he mentioned he believed that Bill Gates's father was a Rotarian, and he thought that this might have been a connection of sort of bringing them into global health. I have not looked into that myself. It seemed a bit beyond the scope of my project, but I did think it was intriguing, all of the connections that Rotarians potentially were having here. You asked about its potential, the foundation's potential manipulation by the state. It's possible that that was happening. In the records that I've seen thus far, it seems much more that Hingson is a relentless corresponder who is seeking support however he can find it, and utilizing his Baptist connections to gain U.S. support or just, permission for some of these efforts. And so rather than seeing the U.S. government saying, oh, this is something we should take advantage of, I see, 8 letters in them saying, great, this is wonderful work that you're doing, keep up the good work, rather than seemingly any recognition of the ways in which his efforts could be kind of manipulated more for the aims of the U.S. state. It's possible that was happening, but within the limits of COVID, I have tried very hard to find evidence of that through the records of presidential libraries or the State Department, through a lot of examination of naval records, and I haven't seen that yet. This question about state hegemony and the links between soft and hard power, and the idea that the Pentagon has soft power institutions too, is something that was relatively new to me. I had never done research, I guess, except in the provision of security assistance to repressive governments that intersects with my human rights work on the Pentagon before. And so I was really interested to learn about the different ways in which the Pentagon does engage in these sort of soft power efforts, whether it's I had thought when I first learned about it that the Navy carrying Hingson and his supplies, say, to Liberia or to other places, that might be unique. And I was interested to learn actually about the many different ways in which U.S. military forces are put at the disposal of humanitarian organizations, and the ways in which in the late 1950s into the early 1960s, American military officials thought much more deliberately about how they could use the resources of the Department of Defense in a kind of Theodore Roosevelt. I saw, Giles, your teddy bear behind you earlier, and so I was thinking a bit about Roosevelt, but a different conception of the Great White Fleet, and having the U.S. military be undertaking missions overseas, but to facilitate the eradication of disease or the alleviation of material conditions. And so that's something that I would be interested certainly in expanding upon for the paper. So thank you. And these are amazing comments. I'm just delighted that you're interested in learning more, that the paper provoked you to want to learn more about Hingson and the foundation, because often when I was doing this work, I felt like, oh, will anyone actually care about this tiny little thing that I stumbled upon in the archives and became myself fascinated with, but would anyone else actually ever be interested? So thank you so much.
No, if I might just say, I think because of the work I've done has been principally on the big corporate philanthropic foundations, you're often hard put to find examples where philanthropy is philanthropy. It is driven by a love of mankind and not a love of greater power. And so I think it's a great example. It seems to be at least a great example, in fact, where it suggests that you can collaborate with the American state or state agencies or even the Navy without necessarily being suborned by it and manipulated into doing something which you may not otherwise want to do. And so I think it forms a good example of genuine kind of philanthropic effort, and long may that last, as far as I'm concerned. People benefited from it in various ways, and there wasn't a hidden agenda. It was what it said. And the fact that it was grassroots, it's almost like this kind of crowdfunding, but in a kind of in a old school grassroots funding, and it suggests that then you do not become indebted to any particular interests because you have a large number of small donors, and I guess in a way it may offer as a very good model for maybe studying other smaller foundations and philanthropies, but also for philanthropies which have a very clear idea of what they want to do and how they retain their autonomy from being kind of swallowed up in these big networks, which I'm sure there are temptations when one becomes a major organization or attempt to become an organization and grow, to temptations to compromise somewhat on one's underlying principles and make make deals and agreements with which one may not be very happy. So it was really refreshing to me to read such a wonderful, humane example. And Hinkson, as you said, I think he's amazing. I mean, I'm just shocked I never heard his name ever before. And why his name is not, and a statue of him isn't somewhere prominent. I'm shocked. Or maybe there are statues in Ohio somewhere, but clearly an exceptional individual, and you've done well to find and uncover, and maybe there's a lot more out there of this kind which we don't know too much about.
If there is a statue, I should find it and include a photo.
Yeah.
We'll put it on the cover of the book, Sarah.
That would be great.
Yeah. No, this is definitely a wonderful subject for this event and certainly the ensuing publication, which we hope to develop. Just in the interim, as perhaps our participants are considering possible questions, I would like to pick up on one thing, the Baptist element that you referred to. Yesterday, Jonathan talked about, he made a reference to the gospel of public health in relation to the response to Spanish flu after World War I. And I think there's one thing here that we need to really get a grip on and consider is the importance of, let's call it faith-based motivations for dealing with public health. I think it's resonating through a lot of the papers in this conference, and it makes me reflect. I say faith-based deliberately and not just Christian, and there's a reason for that, because I was also reflecting on that very interesting exchange we had with Bob Erez and myself yesterday, and Sarah, you actually triggered that exchange about reflecting on what's the connection between smallpox eradication in Africa in the mid-60s and the Vietnam War. And I mistakenly said, it was about, communism is central, that kind of anti-communism is the drive. And I realized, no, communism is external, it's an external threat. What I meant to say was that there's an internal drive, there's an internal faith-based drive. Why US interests, the multiple foreign policies that Erez talked about, are going after literally monsters to destroy, be those monsters disease or communism somewhere else around the globe. And I think faith in that sense can be not just Christian-based and Christian morality and the Christian gospel, but also faith in modernity and progress. And it's often how those two combine that we're really getting to the heart of how public health is recognized as an issue that requires large-scale response and how it's responded to. So it's been very useful for me to reflect on your paper and the connection with what was said yesterday. I would like to give space to others who if they would like to come in on any particular aspect of Sarah's paper. Maybe I can just add another comment. The idea of pistols for peace is, that's a real gem. And also from the fact that these jet injectors are coming from the Pentagon themselves gives it an extra resonance. And because we're talking about the mid-60s, it gives a whole new meaning to guns or butter, really, which is quite striking. So I don't really know where to go with that now, but the connection between the two strikes me as worth reflecting on a bit more. We have a question from Naomi. Naomi, please.
Thank you, Sarah and Inderjeet, for these remarks and reflections. I wanted to reinterrogate a word that both of you used with slightly different meaning to describe this as a grassroots foundation. In a lot of global health history, this actually, the premise of this particular foundation would be seen as the opposite of grassroots, because it's designed by the inventor of a vaccine injector, who then uses the vaccine injector to go into countries and introduce or add to immunization policies and practices, and then leaves. Okay, so this is definitely not how a lot of global health historians have called grassroots. This sounds a lot more like the Rockefeller Foundation, at least in its early decades, which was famously known to go in, give people shots, or sometimes including shots of penicillin or pills, and then leave, right? Arguing that they had focused on a particular disease, or sometimes two diseases, and then that they had made a difference in morbidity and mortality, and then they would leave without any effort to address health systems in that particular country or region. So here I see what sounds like a humanitarian physician and inventor bringing his invention to the developing world, using it, and then, well, leaving. And that seems, so it seems like that's an odd way to describe grassroots exactly. So Sarah, I was hoping that you might want to talk about that a little more. And also I wondered about the Costa Rica example. How were the 84 volunteers, including the medical professionals, how were they chosen? Were these people that he had met personally or had recommended to him through Baptist connections or Rotarian connections? So that was an additional question that I had.
If I may just step in, I see Erez also has a question. So Erez, if you'd like to go ahead, and then Sarah will have about 5 minutes to reply. Thank you.
Thanks very much, Giles. Sorry, I hope you don't mind if I don't turn on my camera. I'm not really camera ready at the moment, so I'll just join as a disembodied voice. But good to see you, Sarah and Inderjeet as well, and really terrific conversation. I was, you know, Giles, I was really taken with how you brought our conversation yesterday. I don't know, Inderjeet, if you were present for that, and have sort of since developed it in, I think, really fascinating, the fascinating direction. This idea of both, you know, communism and smallpox, whatever other diseases, being monsters to destroy, and perhaps converging on this idea of modernity. And it occurred to me that one of the reasons that I think that the United States and the Soviets, Americans and Russians and capitalists and communists in the 1960s and 70s could converge on things like smallpox eradication is that actually they had a lot of things in common, among other things, their vision of modernity, what modernity looked like, or at least some aspects of it that they had in common. And I think that's crucial to remember. The other point I just wanted to make with regard to Pistols for Peace, this was as I'm sure you know, is a very common metaphor. I mean, Dwight Eisenhower gave a famous speech about atoms for peace in the early 1950s. And this does the same kind of pistols for peace, that does the same kind of inversion. And I'm sure, I mean, I assume the Costa Rican minister who wrote this was aware of the Atoms for Peace slogan. There's, of course, also Food for Peace, which is a program that's quite common in this, talked about a lot in the 1960s. It doesn't have quite the same kind of irony to it as Atoms for Peace or Pistols for Peace, but this idea of flipping the Cold War on its head, in a sense, is at least metaphorically, is very common. On the flip side, this whole thread reminded me that in smallpox eradication, and Bob, I don't know if he's on. Oh, he is. Will know this very well. In the West Africa campaign, once they got off mass vaccination, they called their system of tracing and vaccinating around outbreaks, they called it surveillance containment. That was the term that they used, surveillance containment. And they were very cognizant of the fact that they were taking this term, of the sort of military connotations of this term, which I think they even, Bob may remember this better, I think they even had an earlier name which was even more militarized than that. And they thought, oh, that's too militarized. We have to use surveillance containment. Bob, I'm wondering if you remember that story.
Yeah. So the first title they gave it was Eradication Escalation.
Escalation, that's right.
Which, you know, given the context in Vietnam, was clearly distasteful on the perspective of people in West and Central Africa, CDC folks. I mean. Yeah.
So Henderson and others said, you know, that's we can't use this, so we'll use surveillance containment instead.
Thanks very much, Iris and Bob. Sarah, would you like a brief comment on that?
Sure. So just to start with the question about Grassroots Foundation, I'm certainly, and I think that this is what the initial question was referring to, about the organization of the foundation in the United States, its structure, its numbers, its fundraising, and it does seem to me that grassroots or small scale, in differentiation from other large scale endowment funded foundations in the United States, makes sense as a useful way of talking about it. In terms of the ways in which the foundation engaged in its medical missions abroad, I completely agree that this was different than previous sort of medical missionary work in which people would establish hospitals, live in communities for long periods of time, or other public health efforts of the 20th century. They recognized that you know, there needed to be a much more sort of horizontal interventions in communities to address issues of public health. That this is very different than what Hingson's doing. He is using his own invention. I haven't seen yet evidence that he derived sort of material benefits from that, say that, you know, he had the patent and every time someone bought it that he got huge amounts of money. But it is interesting potentially to think about if that could have been a motivation for this work. Although thus far, as I was discussing earlier, I haven't seen that. In terms of the Costa Rican mission and how were the people chosen, so Hingson undertook this worldwide, kind of around the world, mission with volunteers in 1958. And after that, he gave a number of talks that led to the establishment of the foundation. And he kept essentially a running list of people who were willing to go on very short notice on medical missions abroad. And so for the Costa Rica mission, he drew upon people who had previously made themselves known to him as being willing to engage in this work. Some maybe overrepresentation of people who worked in the hospitals in his area, but really it was a broad-based mission of people who had either been involved in previous efforts or just knew about his work through either medical or Baptist circles. In terms of this language, Pistolas de la Paz, certainly I'm sure by the Johnson years. The Costa Rican health minister may have deliberately been trying to echo other US programs such as Food for Peace or Atoms for Peace. But the genesis, at least within the Brother Foundation, for talking about the jet injectors in this way was a Burmese child the story goes that in Burma in 1958, Hingsen and his colleagues were giving vaccinations, and one child, a boy, was crying, and his sister said, "Oh, don't worry, I just got my shot. It's not a bad gun, it's a peace gun." And so that is when the foundation started using this terminology to describe the jet injectors because of the way in which they were viewed to be far less painful than other methods of getting vaccination. And I just want to say that I love the idea of eradication escalation. Someone needs to find some way to work that in, because the language it's so evocative.
Thank you so much, and thank you for your paper and all the comments. So
thank you.
We will. Thanks, Sarah. We'll go on to the final part of the session. Richard, you are with us, I believe.
I'm here.
Hi.
Hi, Edward.
Glad you could make it. Richard Mizelle is Associate Professor of History at the University of Houston, and his research focuses on the history of race and healthcare politics, chronic disease, environmental health, and the historic connections between gender identity and ethnicity in medicine. He is the author of, among other works, Backwater Blues, The Mississippi Flood of 1927 in the African American Imagination, University of Minnesota Press, 2014. He will be delivering a presentation today entitled Diabetes and the American Century. And unfortunately, I have to say that the commentator Nina Mackert is unable to join us at the very last minute due to an illness in her family, which required her to make an emergency trip to the hospital this very morning. So that was rather sad news. But she did send in some comments, which I will pass on after Richard's presentation. So Richard, thank you. Please, the floor is yours.
Thank you so much, Giles. Let me join the chorus in thanking you for the invitation. I'm very glad to be here. I am writing a history of race and diabetes in the 20th century, and this talk will represent a very small slice of that project. Initially, this project was going to go through Hurricane Katrina, turn of the 20th century through Hurricane Katrina, but as you might imagine, I'm extending it out to a conversation of COVID-19. And so part of my argument in the entire book is that diabetes narrates the history of the 20th century, from the progressive era to sort of under-theorized notions of Black migration, to the Depression era, New Deal, World War I and II, Civil Rights, Black Power movement, and the post-Civil Rights era. I am at this point beginning the writing of this book, and I'm coming to the realization of what this book is about, but perhaps what is more more liberating, I should say. I'm coming to the realization of what this book is not about. And sort of part of what I'm really facing or thinking about this book is, how much I am interested in these conversations of disability and the complications of diabetes, particularly chronic kidney failure, heart disease, amputations, the complications that we often don't think about. And so recently, historians of medicine have made the case for a stronger focus on the intersection of medical history and the history of disabilities, suggesting that disability history has largely focused on various forms of arcane social policy, architecture, and geography outside the realm of medical pathology. Historian Beth Linker has written that the fields of disability and medicine parallel one another, but with few points of contact. She goes on to say that theories of disability operate on the margins of medical history, but rarely brought front and center to be highly theorized and systematically studied. And so diabetes and disability, therefore, speaks to the broader theme, one of the broader themes of this workshop, which includes the ways in which disease represents a threat to the ideals, values, and capacities of the American century. So I want to do two things in very short order. And if Nina were here, I would have to apologize because one half of what I'm going to say today is actually not in the paper at all. So I'll apologize to everyone else. But diabetes and disability during World War II is the chapter that I'm working on now, sort of starting in the middle of the book and then working outward. But also this question of amputations. So those are the two things that I'll address very quickly. Now, if you do a Google search right now on diabetes and disability, you'll come up with, you'll see a lot of literature. But this literature is in many ways disconnected from the historical past of these questions of disability and diabetes. And in some ways, this literature sort of discloses the many ways in which people suffering from diabetes today don't want to be considered disabled. Sort of in speaking to a close friend of mine who's an activist, but also suffering from type 1 diabetes, she told me about a year ago that calling some people disabled who have diabetes are essentially fighting words. So, placing this sort of broader narrative into play for our current moment is very important. And so the historical record is clear that known and unknown soldiers with diabetes were a cause of concern to the United States military during World War II. The American Diabetes Association, when founded in 1940, helped to inform policy and a broader narrative of disability and able-bodiedness. In Britain and the United States, soldiers with diabetes were sometimes referred to as the pampered favorite class of the war because of special treatment and the extra food rations they might receive. Herman Mosenthal opened the second annual ADA conference as president by saying, while the clouds of war are hanging over us, and continued by addressing the questions of the fitness of soldiers with diabetes. Army regulations and mobilization boards define diabetes as a cause for rejection at military entry points. While some physicians disagreed with this position, arguing that they could be used in restricted or non-combat situations, others, like the well-known Elliot Joslin of Boston, said that it was too risky. Joslin wrote that the hazards which both the diabetic and the government would undergo if they were inducted are so great, and the need for their services in civilian occupations so apparent, that the present rule to omit them appears proper. The ADA and military officials discussed the threat of insulin shock on the battlefield, the need to transport insulin into war zones, and the ability of soldiers with diabetes to perform combat. During the early years of the war, the ADA took note from the British Diabetes Association on everything from emergency allocation of insulin for soldiers, proper food rationing, to the handling of soldiers with diabetes during a so-called blitzkrieg. Importantly, the ADA provided guidelines for military officials to tell the difference between a diabetic coma and hyperglycemia and unconsciousness from a war-related injury. Soldiers were given special identification tags so that they could be easily identifiable for their special needs. On the home front, the stigma of diabetes led to both men and women hiding their diagnosis from potential suitors and employers for fear that they might be considered unsuitable for marriage or labor. For some, diabetes was a hereditary factor that families wanted to prevent from entering into their gene pool. Marrying and conceiving a child with a person with diabetes was often cause for alarm. Here I think of Michael Udell, who talks about how ubiquitous these questions of eugenics has been for the American century, but also outside of the United States as well, that these ideas of eugenics go well beyond what we think of as the progressive era. And so employers worried about productivity levels and feared employees going into comas while on the clock. Physicians often stepped in for certain patients. Cecil Stryker, who was the first ADA president, assuaged the fears of an employer by saying, "I am very happy to tell you that Alfred has been doing very nicely." That's not his real name, by the way, I changed his name. "He has been under my medical care for a good many years and is extremely cooperative." In another letter, Stryker is even more specific. In reference to Franklin, I feel that I can tell you that his diabetes is very nicely controlled and that he does not present any unusual hazard in driving an automobile. And so some of the records that I see, as scarce as they may be, particularly for African Americans working for the federal government, sort of talk about this vulnerability. One individual working for the federal government for 20 years and keeping his diagnosis secret in a certain way of passing in the federal government for 20, 30 years. When his employers found out that he was suffering from diabetes, the employer said, if I had known you had diabetes, I would have never hired you and I would have fired you 20 years ago. So these are some of the questions that I'm grappling with in terms of this notion of diabetes and disability in World War II. For the second point, I recently wrote an essay in The Lancet, a very short Art of Medicine piece on diabetes, race, and amputations, thinking about how uncontrolled diabetes causes severe nerve damage and the hardening of blood vessels that restrict the flow of blood to the lower extremities. Restriction of blood and nerve damage leads to, or can lead to, gangrene, infections, foot ulcers, and peripheral arterial disease. Surprisingly, individuals suffering from diabetes who suffer high amputations or amputations above the knee can have a shorter or equivalent life expectancy of those suffering from certain forms of diagnosed cancer. What is it about suffering an amputation that so drastically decreases life expectancy? Well, part of the answer is that the nerve damage, hardening of walls, and general arteriosclerosis that necessitates an amputation occurs in other parts of the body, leading to a predisposition for heart attack, stroke, and chronic heart disease. And so amputations are in many ways the outward symbol of the devastating damage diabetes has caused inside the body. So persons living with diabetes living in poor and segregated neighborhoods experience a constellation of social factors that lead to amputation risk, including being uninsured, high insulin costs, and the lack of access to revascularization surgery located at large research hospitals. And so foot ulcers and gangrene have plagued those suffering from diabetes for centuries. Yet diabetes-related surgery and amputations were not common until the early part of the 20th century. Nearly 50% of diabetic amputations in 1930 resulted in death. Elliot Joslin, writing in 1950 about a patient's near death from an amputation, talks specifically about the risk of amputations among all classes, but especially the poor. And so part of my, as I conclude, part of this section or this sort of concluding chapter in my book and into the epilogue thinks about this broad notion of amputations, which an amputation is financially expensive. Prosthetic limbs can cost up to $50,000, require replacement every 3 to 5 years to account for changes in the body, and demand months of physical therapy that can be economically prohibitive. In the Lancet essay and my broader book, I argue that zip codes and geographies of vulnerability tell the story of why Black people suffering from diabetes are 4 times more likely to endure an unnecessary amputation, representing an amputation epidemic within the diabetes epidemic. Prohibitively expensive prosthetic limbs take center stage in questions of race and technology. Building on a range of theory scholars from Irving Goffman to Ruha Benjamin, I argue that prosthetic limbs are far from neutral technologies and instead tell us something important about technological norms and user identity. For African Americans and other non-white groups, the stigma of amputations in public spaces can be exacerbated by the inability to find prosthetic limbs to match their skin color, showing the ways in which whiteness is centered as the technological norm. And so, I'm also sort of dealing with this question of sort of type 1 and type 2 diabetes and sort of the lack of awareness around Black people suffering from type 1 diabetes. And this is an increasing emerging patient advocacy group in the latter part of the 20th century and early part of the 21st century. If you do a quick Google search, you will see a wealth of sort of mediums of Black people expressing both their invisibility within the larger American Diabetes Association online communities, but also testimony in terms of mistreatment at the hands of physicians that are historical in the making, right? In the sense that there was, of course, in the early 20th century, a perception that African Americans did not suffer from diabetes because they were not civilized enough. It was considered to be a disease of whiteness. And as Arlene Tuckman has written, a disease of Jewish identity in the beginning. So as these sort of notions, these sort of separation between what we think of now as type 1, type 2 diabetes, there is an emerging invisibility among this certain population group of non-white type 1 diabetes sufferers. And so I'll just stop by saying this is in many ways sort of my own personal evolution as a scholar. I think I'm at this point sort of solidly mid-career. And so I'm sort of becoming much more political in my scholarship and research and thinking about the ways in which my work speaks to broad and narrow patient experience. So thank you.
Thank you very much, Richard. Very thought-provoking paper. I will now take the opportunity to read out Nina's comments, which she sent in by email. And Richard, you'll have, of course, the time to give your thoughts on this. Nina Mackert, I was, among many other things, particularly intrigued by your remark that diabetes differs from other diseases in the early 20th century because it required self-observation and control by affected individuals, and that the management of diabetes thus contained, quote, elements of self-actualization, self-containment, and self-discipline, end of quote. I would have asked you to say a bit more about this, particularly about this ambivalency of containment, of self-discipline and self-actualization. She adds in brackets, this I think is so crucial to a range of health-related practices in the 20th century, of this notion of individual self-care that has become so crucial to health since the, I would say, 19th century. But that also differs across the different diseases and the different health regimes or forms of governing health, close bracket. So related to this, is or was diabetes in the early 20th century foreshadowing the logics of disease prevention after the epidemiological shift of the post-World War II period? And then she adds, I just read Marcia Tuckman's History of Diabetes and Race, which you probably know, that also speaks to your work in a range of issues, and that highlights the shifts in the racialization of disease in the 20th century from its initial association with Jewishness and people deemed particularly civilized and wealthy to a marker of primitiveness and non-whiteness. Richard, yeah, your thoughts.
Yeah, so, Elliot Jocelyn was in many ways sort of crucial to sort of this early narrative of sort of self-actualization and self-containment. He was among the many sort of considered diabetologists who sort of wrote in this narrative of sort of the special, unique qualities of those individuals suffering from diabetes. That the discipline, the self-identification, the management and control that was necessary to be a good diabetic patient made them above average citizens. And so they described a disease that was different from cancer or even tuberculosis, in the sense that, it's not that there was sort of no personal responsibility for some individuals suffering from cancer. You see those narratives, particularly, some of these conversations around motherhood or repressed motherhood, and that's the reason why they were suffering from cancer and so forth and so on. But this conversation of diabetes, of having to measure insulin, of having to appropriately measure insulin and use the vials to inject themselves in a laborious way several times a day, made, diabetics sort of framed or sort of considered to be sort of above average citizens in the ways in which they were pushing this sort of modernity forward in both U.S. healthcare, but also in American society. And so, that narrative, I think, has continued, not only through sort of the middle part of the 20th century, but also the latter part of the 20th century as well, where there is, I do believe, Nina is correct in this situation, in her thought, and thinking about the ways in which there is, increasingly, overwhelmingly sort of personal responsibility that individuals have for their disease, or that's sort of the perception that we have, that you have to eat right, or you have to refrain from a certain kind of eating. You have to, sort of bringing in my environmental politics side, avoid certain carcinogens or environmental exposures. So increasingly over the 20th century, the onus of sort of disease and illness continues to fall upon individuals themselves to deal with the disease, in addition to physicians, public health advocates, and nurses. And this is especially the case for diabetes, right? Thinking about sort of questions of sort of insulin pumps and sort of the increased management of individuals with diabetes today. These notions are in many ways not so dissimilar from what individuals who were suffering with diabetes in the early 20th century experienced and dealt with. So I do think that there's a continuity, and I think this is a point that I make to individuals when I'm discussing diabetes today, that there's a long history. And there's, so much that we really still do not know about the history of diabetes, or its, mechanisms, or sort of pathology. And it's constantly evolving. I mean, even now with sort of the current COVID-19 pandemic, there's some very interesting sort of literature and scholarship on diabetes, or those individuals with diabetes being more susceptible to COVID because of the ACE2 receptors, and people with diabetes having more receptors that can provide entryways. So my point is, diabetes is a chronic disease, but it is still one of the more puzzling, fascinating, mysterious diseases that we have out there, and it sort of takes you in so many ways. The last point about Arlene Tuckman, yes, of course. Her book has sort of been a really sort of launching point for my book. It's nice to have someone who is open and welcoming, even though we're writing on the same topic as, and Matt Klingel as well, who's also writing a more environmental history of diabetes. So I think the field is becoming wide open, and more people are becoming interested in diabetes, and that's a good thing.
Thanks very much for your response. We have a question from Manon Parry.
Hi, thank you. Yes, and I'm sorry, I'm not turning on my camera because I'm in my tiny Amsterdam apartment home office, which is also my bedroom. So just in keeping with the size of spaces here. But I just wanted to say, first of all, that I'm really excited by this project and really interested in seeing more disability history in medical history. So I find that intersection that you're bringing up really valuable. And I was intrigued by your mention of the fear of being associated with disability as still being something that people with diabetes are concerned about today. So I was wondering if you think that is linked to an ongoing stigma of disability as weakness or as damaged people, and if that reflects a kind of lack of an intersectional perspective on disability rights and the structural factors that play into disability. And kind of relatedly, is it about that stigma, or is it about class politics within the populations that you're looking at, and a differentiation between Black patients who can afford to avoid amputation and those living in poverty who are more likely to experience it? And what the history of that is, wherever you see it lying now. Thank you.
Yeah, and I think that's a great point, a question. And these are sort of things I'm sort of, are evolving in my mind as well. I think part of it revolves around class, but I also think part of it revolves around that type 1 and type 2 status. So there's a misconception that only type 2 people suffering from diabetes, or individuals with type 2 diabetes, suffer from amputations or dialysis or some of these other sort of complications. And that individuals with type 1 are not prone to amputations. And so there is really, in some ways, an ongoing sort of race and class split, and a fear of being associated with really Black type 2 poor diabetics or individuals with diabetes. Even among sort of middle and upper class African Americans, but also middle and upper class whites and sort of lower class whites as well. So all of this goes into some of these broader narratives of what disability means, what it means in society, what are the stigmas, what are the ramifications, and sort of what it means in terms of your body. And so where it is, and again, I'm sort of thinking about these ideas out loud, where it is sort of a welcome and some individuals or groups are pushing for this. Others, I'm sure, are pushing for it silently, and others are resisting this idea of diabetes being representing any form of disability whatsoever, or type 1 diabetes not representing a form of disability, that's a type 2 thing, but not a type 1. And so, these are some of the questions and the ideas that you see on this sort of online community that are constantly evolving.
And is that an entirely new phenomenon, or did you see a kind of an earlier history of these differentiations? Because I'm just wondering how tied it is to that notion of personal responsibility as well. And so has it got much stronger more recently?
Yeah, I think that it has probably gotten more, stronger in the last 20 years. Keep in mind that this idea of type 1 and type 2 really doesn't come about until the 90s. And so you start to see this narrative of personal responsibility coming about after the war, when there's sort of more differentiation of type 1 as an autoimmune disease, in the 1940s and 1950s. And then what is sort of now considered to be a type 2 disease was considered to be, a disease of personal responsibility. And to be more specific, sort of Black genes, poor eating habits, poor environments, that were inevitably the result of Blackness is sort of the narrative that you begin to see in the 1940s and 1950s. And then, of course, an important piece of this is the Dialysis Entitlement Act of 1972, passing, in the Ways and Means of the U.S. Congress. And so sort of making dialysis in many ways a form of disability, I think sets, this narrative forward in terms of thinking about diabetes and disability, but also attempting to distinguish or disaggregate, certain kinds of disability and certain kinds of identities from other identities.
Thank you.
Thank you very much. And we have another question from Naomi Rogers.
Thank you, Giles. Richard, I really enjoyed this paper, and I loved the depiction of a white person coming before Congress to explain by practice what dialysis was when there were debates about whether or not Medicare could fund it. And so I have, I wanted to ask about that. So Congress does fund dialysis in 72, as you just mentioned. What difference did it make? What difference did it make for a range of people who had diabetes? And what difference did it make in terms of the way that diabetes was understood? And the other more just brief comment I want to make, that the quote you just gave us from Jocelyn saying that in the early 20th century, diabetics were special people. I wondered if they were white special people.
Yeah. Yeah, absolutely. Answer the second question first. And this is a question I actually had a conversation with Arlene Tuckman about this maybe a month ago or 2 months ago. I really don't know that much about Jocelyn's politics. His records don't disclose a lot, but what I do know is that he was in many ways sort of centering this idea of whiteness, that sort of whiteness and sort of special needs or sort of better than average citizen was sort of part of what he was sort of thinking about and sort of framing in his narrative. He does not really address various questions of gender or race or the difficulties that certain individuals might have in laboriously injecting themselves with insulin several times a day, the housewife or the sharecropper. Or the industrial worker. The reasons why it might have been more difficult for them to follow this strict guideline, he seems to either ignore or be oblivious to. As to your first question, I think in some ways, and I've sort of worked on dialysis in a number of different ways. I have an article I'm working on now on the Seattle Artificial Kidneys Center in Seattle in the early 1960s. But I think, similar to diabetes, there was a perception that the dialysis or kidney failure was a white disease. And so, in Seattle, you see these ideas that Black people don't suffer from kidney disease, and you see this early in the century. And of course, my argument in the essay is not, and in the broader book, is not that Black people suffer from diabetes or kidney failure too. That much is obvious. But what is the willful ignorance, the agnotology, or sort of the science of unmaking that makes it difficult for us to see this exposure and this experience, and what was the process of racial making of sort of normalcy and abnormality when it comes to Black disease. And so all of this is coming off of the civil rights movement, Black Power era, in which there is sort of a push for more awareness, more engagement with those diseases and illnesses that are impacting African Americans. And so for dialysis and diabetes patients, it changed their way of access in significant ways, but continued to limit their access because of the ways in which sort of access to dialysis, continued to be fraught through questions of transportation, but also larger questions of poverty. So they had access to it, but what we see is, in the 70s and 80s, it was still difficult for, diabetic patients or Black people suffering from diabetes, and poor people and other groups of people to access this form of dialysis. But dialysis is important as well, and you sort of mentioned this sort of white consumer on the House floor of the Ways and Means. That's important because, in a certain sense, that was the way in which dialysis legislation was passed. I mean, that could have been any of a number of different things, from drug technology to hemophiliacs to sort of put forth an entitlement law through U.S. Congress, but they chose dialysis because of this sort of normalcy of whiteness and dialysis and kidney failure. The image of this individual on the House Ways and Means floor, but also what it meant for the broader overall white health, which in some ways influenced Black health, but continued to do so in very limited ways.
Thank you. Perhaps while others are considering questions, maybe I can come in on the very interesting things you've been saying about the racialization of health, and particular health concerns, and how a particular illness, something like diabetes, can literally shift in terms of how it's racially perceived. And I find that really, really interesting. I think Naomi mentioned it in relation to polio as well yesterday, in a different way. But you said, Richard, that there's this period in the 40s and 50s where diabetes starts to become more closely associated with Black American population. And I just wondered if you could unpack that a bit more for us, what's going on, why in that particular period. And one thing that just comes up in my mind, and this may be completely misnomer, and it doesn't address the issue head on anyway. But yesterday, when Jonathan was talking about the response to Spanish flu and World War I and the crucial nature of World War I, that the notion of national security came up in my mind, about there was this connection between disease and the capability of the nation to wage war, and it is a kind of national security conception. And I just wondered if that was also in any way related when you start talking about World War II and diabetes and waging war. And I just wondered if you could say a bit more about that broad issue of how that happened.
Yeah, so as I mentioned before, the evidence was clearly there. I mean, one body of knowledge that I use that I think is really underrepresented is Black insurance company records. They were really at the forefront of sort of exposing sort of the high numbers of people suffering from diabetes in certain communities in New York City. But this is also where the state comes in, because again, I think that this question of the Great Migration to cities is vastly under-theorized, that Black people moved to Chicago and New York and Baltimore to escape sharecropping and violence, but also for better prenatal care, better obstetric care, better sort of public health infrastructure. And so that brought them into sort of under the guise or the surveillance of the state. And so the state responded to that by essentially, producing more documents about this population that was coming into places like Chicago and Baltimore. And, sort of in a sort of a roundabout kind of way, the migration of Black people pushed the narrative forward. And so by the 1930s and 1940s, now you have public health departments saying, wait a minute, this group of people are suffering from diabetes too. And so then you have people responding to those public health reports, producing other kinds of documents. And related to that, then also is sort of what Matthew Fried Jacobson describes as sort of the making of whiteness, right? So as this question of Jewish identity and whether they were white, as during the era of segregation and Jim Crow, in this sort of consolidation of whiteness, as sort of these sort of different groups of people were brought under this umbrella of whiteness, then the Jewishness special identity of diabetes, their special, vulnerability to diabetes as a disease of civilization, as a disease of modernity begins to fade away. And so when they are sort of brought into this umbrella of whiteness, that's when the narrative begins to shift, along with sort of more public health representation or more public health surveillance over Black populations, to begin thinking about this idea of Black diabetes in cities in particular, but also slowly in more rural areas. So it was a combination of those things, but also, to your point, brought about by the war as well, sort of increased surveillance. And one of the points that I make in this particular chapter is that Army induction centers, we're noticing a high number of cases of diabetes among African-American soldiers. Now, I'm not going to profess to say I have a whole lot of documents on that, but, I have a few, and the few that I have, I'm stretching. But what that suggests to me is that, even the military and sort of this question of war and this question of science is being forced to shift in response to something that they had not really thought about before, which is the presence of Black soldiers with diabetes. So I think it was a combination of those three things that you see in the 1940s and 1950s, but also, sort of changes in diabetes drug, sort of the creation of RNAs, some of these other sort of features that are also pushing this narrative forward of sort of Black abnormality, but also Black normalcy as well.
Thanks for that. Yeah, the Great Migration I see completely changes the whole context. It's not, the war is just one of several other important factors. Maybe I can come on with another one. You say something really interesting about in your paper about technology, and you referred to Rua Benjamin's work, and how there is this tendency to apply technological fixes in ways that completely obscure socioeconomic inequalities. And I think that what you're pointing to there, I think, is something broadly significant for public health in general, right? Or do you think there's something specific about the diabetes story that makes that link between technology and socioeconomic inequality particularly visible? I was thinking about amputation, of course, is a particularly visible form of physical inequality. So maybe that's the issue here.
Yeah, no, I think it makes it highly, visible. I mean, you think of someone of a Black woman having to put on brown stockings because that prosthetic limb is white, or someone having to wear pants in the dead of summer because the prosthetic limb. I mean, there's sort of a psychological thing that occurs when having to wear a fixture or prosthetic limb that doesn't match your skin color. And so, I think what Ruha Benjamin, is sort of highlighting is that, of course, technology is political, sort of, building on, of course, Langdon Winter and sort of others. But, there is this sort of idea that there are things behind technology sort of pushing the question forward that we must also address. And so I make a similar point with sort of the question of dialysis during the Seattle Artificial Kidney Center. Sort of my essay sort of pivots on this idea that some scholars have made that race was not an issue in early dialysis in Seattle because there was such a small Black population in Seattle. Well, Seattle was no Chicago, but you have Boeing there, and you have quite a large number of migrants coming into the city between the 1930s and the 1950s from Alabama, from North Carolina, who are sort of seeking these Boeing jobs. And so it's illogical to think of a population, a Black population in Seattle who are not in need of dialysis. And sort of looking at death records and some of these other records, you see the number of people who would have been available or eligible for dialysis, but you have this patient lay committee, what was called the Patient Admissions and Policy Committee, sometimes referred to as the God Committee, who make certain sort of requirements for access to dialysis. Like you have to be referred to by a physician, or you have to be in a company that is amenable to dialysis. And those two issues are important as well, because there's segregation in Seattle, and it's difficult for Black patients to move into spaces of having a physician send them via referral to the dialysis committee. And Boeing was segregated until the 1970s. So if you're sort of advocating for people coming from Boeing, well, Black people were locked out of Boeing, and so it's difficult for them to move in those spaces as well. So we can't just look at technology as technology. We have to place it within sort of this broader narrative, and I think that's what Irving Goffman and Ruha Benjamin sort of help us to see.
Thank you very much. Yeah, no, this is going to be a great book. I don't know, you're still in the middle of it, right?
I'm in the middle-ish, early stage of writing. I'm pretty much done with most of the research. Pandemic has put me behind a little bit, like all of us, but I'm in the writing process now.
Okay. Thank you so much for joining us today, Richard.
Thank you.
Our thoughts go out to Nina as well. I'll be in touch with her, and hopefully with good news. That brings us to the end of our second day. Thank you very much once again to all speakers, commentators, and participants in general. And we'll be meeting up again tomorrow afternoon, 2:30 Dutch time. And that will be chaired by my RIAS and Leiden colleague, Damien Pargas. So until then, I wish you all a good day. Thank you very much once again, and see you tomorrow. Bye-bye.
Thank you, Giles.